Suzanne, my parents live in Chapel Hill, so I go back pretty often, and I was there for what was that? The tropical depression, whatever it was, and I might like just sidewalks and everything was wiped just for like a little, not a
Yeah,
little, but it was really took out a good chunk of the town there from like an unnamed
yeah,
storm, you know?
yes, yes. Yeah, that's why we get nervous now. Because like when they
Yeah.
said Imelda was coming, I was like, oh
Oh
no.
yeah.
So, well, we're gonna go ahead and begin. I'm just making sure that um, we get the recording going.
Sounded like it said so.
It is okay.
But I
So
mean, I don't know. Things could have changed. I just heard it. Oh, there it is. Yeah, I see
You're good,
yeah,
Suzanne.
super. And something must be wrong up with mine
it.
tonight. So welcome everybody. We're so glad you're here tonight. This is the Business of Health Career Networks program, Healthcare Payers Panel. So we're glad that you can join us for the evening. This is part of the UNC Center for the Business of Health Career Networks program. Career Networks is a constellation of resources meant to educate and create community around the continuously evolving healthcare ecosystem. You can explore the CBOH Career Networks platform via the URL that I'm actually pasting right now into the chat. And for tonight's panel, we ask that you turn your video on and mute your microphone while not asking questions. If you are in clinic or somewhere where you cannot share your camera, we understand. Tonight's panel will begin with our guests introducing themselves. Then I'll be asking some moderated questions, and I'll stop every two for questions from our audience. If you have a burning question, don't worry about it. You can raise your hand at any time. But when we do stop for questioning, please raise your digital hand if you cannot use the audio. And feel free to paste your questions in the chat box again if you're in clinic or somewhere where you cannot engage verbally. I'm Suzanne Killian, the Associate Director for Student Engagement with the Center for the Business of Health. And tonight I have Erin Leach, our Program Manager behind the scenes with us, who's running everything and making sure everybody gets into the room. Tonight we have with us three outstanding panelists. We have Amelia Moore with Humana, Luke Redman with Homeward Health, and Derrick Brusseau with Centene, who will share their career journeys and introduce you to the industries from their diverse perspectives. So to begin, I am going to let them introduce themselves. So I'll let you all take it away, and I will let Luke start since he's up in my left-hand corner.
All right, sounds good. Well, hi everybody. Thanks for making the time tonight. My name is Luke Redman, and I graduated from UNC in 2009 with an MBA MHA through School of Public Health. And before I came back to grad school, I was an Army officer for 4 years. So I did that between undergrad and grad school. And after I graduated, I was at Deloitte Consulting for a couple of years. Before moving over to the payer side, I worked at Blue Cross Blue Shield and Aetna. And then I ran a medical practice in Texas for 7 years before moving over to the startup side of things. And so the past several years, I've been working for Strive Health, which is a kidney care startup that contracts with insurance companies. And now I work for a company called Homeward Health that's focused on Medicare Advantage contracts for rural Michiganders. And I'm the market president for the Michigan market. And I'll pass it to Amelia.
Me. Okay. Hi, I'm Amelia Moore. I graduated from Keenan Flagler in 2020, but before that, I also attended UNC undergrad, so I did it twice. The first time was distinctly not business related, so I spent some time actually in HR for the first part of my career, which was great. I was first in public education and then moved into a provider healthcare role, and then made the transition over to payer after business school. So I started with Humana in 2020. And I've held a few roles since I've been here. I started in a like consumer and provider service operations strategy team. And then I took a little jaunt over to our Medicaid line of business and helped stand up our provider support model for the Medicaid segment, because previously we were running on the Medicare Advantage chassis, and there's just some distinctions there that we needed to account for. So that was a really fun effort. And then from there, I have expanded and pivoted slightly. I don't know. I'm supporting now the implementation of our new contracts, and specifically in the realm of provider network build and provider services, getting all that up and running, and caring for any unique contract requirements that we have or commitments we've made that we don't have actual capability to deliver yet. So I get to work on those fun things in my role now. So I think with that, I will kick it over to Derrick for the intro.
Thanks, Amelia. Good to see everyone tonight. I remember, Suzanne, in my time, everyone attended the pharma sessions, and there weren't as many of the payers, so it's great to see a lot of payer folks here interested. So I work for Centene. So for those that don't know, Centene is the largest, not only Medicaid payer, but also in the marketplace side of business, Obamacare, in other words. And of course, a lot of change going on in those two lines of businesses. We also have Medicare Advantage as well. And so, I'm a career changer. So I did real estate development, graduated in 2022 at Keenan Flagler. And so I did the Optum launch leadership for my internship. So if there's any questions about that, I'd be happy to answer either offline, one-on-one, or in here. And then also, so started at Centene, they have this rotational program. So it's 2 years consisting of 3 8-month rotations. And I think the rotational program has its pros and cons. And so luckily for me, I ended up at WellCare of Kentucky, which is a health plan at Centene. So Centene has 31 separate state health plans. And so in this role, I'm a strategy manager, which is really, so it's a lot of synthesizing data. So looking at claims data, looking at trends, and trying to kind of devise strategies to how we can reduce costs, bend the cost curve. Where are we trending high? What do we need to do? And so there's all sorts of things we can get into as far as the levers you can pull. But that's kind of my role, and I've been in that role for a little over a year now. So
Terrific. Great introductions from our panelists. And again, too, hopefully our audience can see how diverse even just the singular vertical of payers can be. And the next question, or actually my first question might be, because sometimes it's a little nuanced, but I'm going to ask our panel, what exactly is a payer?
I can take the first crack.
Go for it, yeah.
I would say a payer is any non-human that is funding healthcare. So, we think a lot about payers as like the ID card that you carry in your wallet, but there's also government payers, the Veterans Affairs, Medicare, Medicaid, those are government payers. So, and I would say people can move across, like it's not very distinct. There's like the commercial and the government side. People can work on both sides of those things. So I would think of a payer as like anybody that you're seeking to reimburse care that you're getting.
Yeah, and I think where I was going was definitely agree with that. But like, if I think about even Humana or I guess a bit to Derrick's point about Centene too being covering multiple lines of business, but like at Humana, there's this push to be like a healthcare services company as well as a health insurance company. And I know Derrick, you probably saw some of that at Optum and United as well, but like I think that there is that sense of like, how do you reimburse care? But then that also expands into, so how do you deliver it and how can you find synergy there? And, a lot of traditionally payers are also looking into or they've got developed these more payer agnostic care delivery services and lines of business that have been launched. I mean, this is not terribly recent, but it is it is another facet of things that you'll see in companies that maybe are your more traditional payers. There's just, that's the thing I tend to highlight is there's like a lot going on under one roof, at least at Humana. And I think that's true probably of a lot of other payers as well.
Yeah, I think yeah, and it's interesting time in a way because I guess sometimes I think of it as like who's taking the risk, and so I think my colleagues here, they have more experience in value-based contracts than I do, but now there's a trend, of course, for providers to take on risk. It used to be just the insurance companies, and now they're trying to get a little more skin in the game for the providers, see if they can sort of motivate them to improve outcomes, higher quality, those sorts of things. So it is an interesting time. To Amelia's point, it's kind of getting a little more blurred.
Yeah, actually, I think Amelia's point's really astute because, like when I was a kid, an insurance company is a financial services product. That's not what it is anymore. It was not that different from auto insurance or something. Now, these are highly diversified companies. They deliver care, they invest in startups, they do all these other things. And, that line has become, it's like a Venn diagram. We're also now you have providers
Like,
and insurance things,
yeah.
yeah, exactly, and vendors doing insurance things. So it's a whole ecosystem unto itself.
Terrific. Thank you so much. I think that clarification is really important, especially as we move on to talk a little bit about your roles and some of the skill sets needed within this vertical. So that'll be my next question is, what is your role, your job role, and what steps did you take to land in your current career?
I'm like looking at y'all to see if anybody wants to go first.
Why don't you take it, Amelia?
You want me to go? Okay. I was
Go.
like, look, I was like, Derrick, you have a cool one because you switched. But let's see, what steps did I take? So obviously going to business school was a big one. I was working in provider healthcare at the time. And that is, I kind of ended up getting, because it was a small company, and I was working in HR, so I was already like had a bit of I was proven to be trusted with confidential information. And so like I was helping because there's some linkage on like the finance side and like that impacts operations. And so I was looking at the whole ecosystem. I just started to realize that everybody I was working with were MBAs. So I was like, maybe I should do that. And I did. The other thing that I noticed through that experience was that, we were doing a lot of really cool things. We had actually gotten a grant from CMS to develop a reimbursement model for, it was palliative care, specifically. But the opportunity for innovation in healthcare was what was really like driving me. And I just started to feel like in a provider environment like that, you are so constrained by the payer setup and the reimbursement setup. And so it's not that there aren't opportunities to innovate, but just like the opportunities there are to innovate on a larger scale come from where those reimbursement models are being defined. And so that's what took me into the payer realm, as opposed to like pharma or, sticking with provider healthcare. Nothing wrong with any of those, just sort of, I thought a lot about what it was I was interested in and where those opportunities were the greatest. And so then, getting to Humana was kind of like which payer is it? And at the time I was recruiting, like Humana just kind of met a lot of my, personal and career goals. But I think a lot of those like HR skill sets, like the people management, soft skill type of stuff, like so much of what I do is, like understand people's objectives and help them understand mine and help us figure out where they overlap and how we can, achieve them together. And perhaps at even a greater scale if we do it together. But in a way that is like, it's not always quite as straightforward. And so it becomes sort of this like psychological dance of just like, what is it that you're concerned about and that you're prioritizing? What am I concerned about and what am I prioritizing? And I feel like, I don't know, honestly, even some of just the communication skills and like, knowledge, skills, abilities, experience, all of it, formal and just experiential, that I got at Keenan Flagler and elsewhere, have been the most useful, which sounds kind of basic and not that fun, but it is true. Like, that's so much of what it is just understanding motivations and objectives and figuring out how to make them align.
Soft skills.
Yeah.
I would think, yeah, that's kind of where my head was going. I know it sounds so cliche, but soft skills are kind of, yeah. But it matters so much, and so I guess I can start where how I got here is, I initially actually came to Keenan Flagler because of the real estate program. I was in real estate, and then kind of wanted to get into a more altruistic career, and realized that like switching within business school is totally, it's doable, and so kind of just started doing research, outreaching to alumni, attending events like this, working with Suzanne and the team. That's it. Kind of just like, you just need someone to give you a chance. Centene was that one for me. And then from there, I mean, I guess I have a finance background, and kind of like in the previous point we were making, these payers they're gigantic, and I had no idea the amount of roles that existed when I started versus now, all the different teams, and you could almost make the argument that they're almost too complex because there's so many different teams. It's almost hard to find the right person to talk to at times. But I think for my role, it's okay, can you interpret data? Can you work with other people cross-functionally? Are you going to make this person mad? Again, going back to the soft skills stuff. And then I will say, if we had had this maybe a year ago, I would say like things such as knowing SQL would be like a cherry on top, knowing how to do those things, at least in more entry level role, because you're pulling claims from these databases that you can't just, snap your finger and they appear. And now, and we can get into it, of course, but like AI, we've developed tools that you can kind of, it'll spit out the SQL query for you. And so it's not going to be perfect. It's still useful to know SQL. In 5 years, I don't know where that will be. But I think still being able to write code like that is super useful, and you'll definitely separate yourself from a lot of folks if you know that, at least in this specific role.
My answer, I suppose that, I mean, first of all, I'll say I don't think I've ever done the same thing twice in my career. All my jobs have been different. Some of it I call kind of the Goldilocks thing. Well, the soup's too cold, the soup's too hot type thing. And I'm still trying to find exactly the perfect fit in that way. But as my career's gone on, what I've kind of found is that I've accumulated some combination of like subject matter expertise that's a little precious, and expertise and like actual experience that's a little precious. And I feel like I bring that stuff to bear in my current job every day. So as the market president, I am responsible for the profit and loss of our contracts in Michigan. So we have a little over $1 billion, $1.2 billion of premium that we manage at full risk, which probably may not mean anything to you all, but just know it's a lot of zeros. The numbers are pretty humbling for sure when we look at every month. But and what that really means is these are very like high value contracts to both our company as a startup and us trying to have a successful IPO, and to the insurance company that gives us that risk. So that kind of high wire act of administering the contracts, it takes expertise in the health policy, contract administration, contract law, and then we also deliver care to 100,000 Michiganders, and so I have to understand some things about medical practice. And for the most part, I feel fortunate I can kind of divert my talents day to day on what I want to spend time on. And I've got a capable team that can do most of the things I don't want to spend time on. But even as I'm kind of developing them, I'm finding there's like these higher order tasks or like these really complex problems that can overwhelm them. And I think if you accumulate a nice diversity of experience and expertise, you can synthesize, you can like solve problems that haven't been solved before. And that's what I think is really, really valuable at executive level.
Tomorrow, there will be.
Terrific. Thank you so much. Again, to I think you all did a great job of just kind of, expressing, first of all, your great journeys and how diverse they are, but also how different your roles are. And Derrick, I loved how you said, if you talked to me a year ago, I would have said one thing, because I do feel that that's part of kind of what you're saying. And when we're talking about the soft skills nowadays, it's just also being nimble. It's being able to change and pivot and turn any way that you need to turn with all of the changes that are going on, but still have a really great base, because it sounds like you all have a strong base in a number of skill sets, albeit technical or those soft skills. So I still think that skill building is super important. All right, so I'm going to open it up to our audience right now. Again, the first question is always the hardest, but be that brave person to be the first to raise your hand. But if you do have a question, please raise your digital hand and we'll call on you. I'm going to do the uncomfortable, 15-second pause.
We need Jeopardy music.
Yep, exactly. All right, Claire, go ahead.
Okay, my question is, you guys mentioned how a lot of payers are also starting to absorb more of the provider roles as well, or even just like the pharmacy benefit management roles. What are some of like the pros and cons you guys see of that movement in your spaces? What are the good things about that trajectory, and maybe some of the things that create challenges for your space?
Luke, do you want? I feel like you might
I was
be,
gonna
since
say
you've
Luke
worked
should
on
probably
both
go
sides.
first.
Yeah, I think I think first of all, it's kind of like a lot of things in healthcare, it's a cycle, and it's going to swing this way and it'll swing back the other way. A lot of things also, I'll say, in particular with health insurers, are kind of from a strategic point, like a Me Too thing. They see somebody acquiring primary care, and then everybody's like, "Why we need to require primary care?" Where you been? And so that the industry tends to kind of move in packs that way, not always for reasons that are like, that make the most sense. But I would say that in general, it's probably a strategic distraction, in your strategy courses. So I'm sure they say, find out what you're good at and only do that. Don't do other things. And insurers aren't very good at delivering care. But that's not to say that it doesn't make sense for a time, and I think that we're in a moment where it's economical for a lot of them to do it. And it's some combination of like they're managing a lot of risk and they have enough market power where it makes sense. And then sometimes they can get a really good deal on like some startup that does that, and they're just acquiring that startup, and it makes sense for this or that reason. But I would say it's not always the case. Like there's a lot of like going back, I was saying before, these companies are financial services companies. So think of them a little bit more like an investment bank or a bank. They do things where you may not always be able to divine the strategy, but there's a purpose to it, and it usually makes sense at the time. And so I think we're at a moment where that's happening because transactionally it makes a lot of sense. But are they good at it? Will they ever be good at it? I don't know. I don't think we've really seen that animal yet, except for maybe like a Kaiser or something.
Mm-hmm.
It's tough. I feel like it's easy to be cynical about it, and I probably lean towards that side of it. But they're all playing within like the rules that have been thrown at them, and so if that's the best that in this capitalist market that they have, I think to Luke's point, yeah, it makes sense to do it.
Yeah, and I mean, I think like there's an idea that you can sort of funnel members on your own plans to your own care assets, right? And again, I mean, I think that Luke's point is a good one of just like, I don't really know if we know how valid of a hypothesis that is, that will yield, returns. But I mean, it is kind of funny too, because it is like, I think Derrick, to your point about the structural elements, like the structural elements in large part, like the payers are dictating some of those. Obviously, like there are constraints, regulatory constraints above payers, but yeah, it's just interesting to watch the way everyone's trying to innovate and like whether that's getting more proximity to actual patients, whether they're members or not, or adjusting like the reimbursement methodology to or the risk sharing, you know, to sort of encourage behaviors in patients and providers. Yeah, it's interesting times. Not sure we know. Didn't really add much there, just saying.
Well, I mean, I think I will say, as much as I'm getting my jury's still out on whether or not it's a good idea, I can tell you why it's very tempting. You know, in healthcare, data is very siloed. There's a lot of mistrust between providers and payers, and so I think it's tempting to think that you can just like vertically integrate and some of those problems go away. But you know, I kind of like to joke that in healthcare, the status quo fights back really hard. And so, as much as it may make all this sense downhill logically and strategically, those things are always harder to make work in real life.
Really insightful. Thank you so much for those great answers and the great question, Claire. Thank you. Any further questions at this time? All right, we're going to move on, but that doesn't mean you can't ask any questions in the moment as we move through. I know the panel already talked a little bit about their skills, abilities that they use daily in their work, but I'd like to just dig a little bit deeper to talk more about like the experiences that you've had and the deeper skill sets that you use regularly or most often in your current role. And also, were there any that surprised you? Like when you first, got into this vertical in payers, was there something that you do all the time that you were like, wow, I didn't really know that I was going to use that skill so often?
I am consistently it's not that the skill itself surprises me. I kind of consistently have to remind myself, like, I think Derrick mentioned this earlier, but just like the complexity in place at a payer, and like the degree of specialized knowledge that some people have of their areas and how their technology works or how their processes work. Like, I've found that one of the ways I can be most useful and effective and really bring something that no one else is bringing, but that comes very naturally to me and is like what certainly business school trained me to do, is like zoom out a little bit and look at sort of the whole picture for a bunch of really specialized folks. And Luke, I'm sure you've had this experience as a consultant too, just like that ability to step back and say like, all right, well, I think this is how we're defining this problem. Like these are its component parts and these are the people that we need to weigh in and help make decisions about, like, and these are frankly the decisions we need to make. A lot of times, like the folks that are experiencing the issues that need to be solved aren't even able to like articulate that. And so that's one of the things that I found myself doing the most. And I guess what surprised me about it was the fact that it is something that kind of comes relatively naturally to me. But it seems to be very helpful in these situations. Even though, it's again, like we're all focusing on our own thing. And if I'm way down in the weeds of how this system works, I really don't have a chance to like look up and understand how that's impacted by and impacting other things up and downstream of it. So that's my thing.
Yeah, I think like that second order thinking, the expression of like to a man with a hammer, every problem is a nail. And so like an example would be we have a network team and if there's a provider who's driving, outlier, bad outcomes or something, their immediate reaction or suggestion might be to terminate them. And of course, like it's not as simple as, I mean, that of course solves it in such a near term instance, but to be able to have that second order thinking of like, okay, are we considering the member in this instance, like, are they in a rural area? We might just be eliminating, the one provider in that county, which of course isn't even allowed, but just to use this as an example. And so, yeah, to Amelia's point, that second order thinking and kind of like the critical thinking of like, there's so many times where no one really you might be in a room of 10 people and no one really has the perfect answer, but like not even being afraid to I throw out
Yep.
dumb ideas all the time, and because I'm new to healthcare, and so, but like if no one throws out that dumb idea, maybe other people are thinking about it, or maybe it's not such a dumb idea, but I might hold it in and not say it, and then we leave the room, and that's a 30-minute meeting that we could have all gotten back and wasted. So I think that critical thinking, it sounds so cliche again, but being able to like really dig in and have that second order and critical thinking is kind of what employers are really looking for.
I could not agree more. Critical thinking was definitely going to be my answer. I think partly because, in the payer space and in the vendor space where I work, like it's all about innovation. And, a lot of smart people have cycled a lot of times in healthcare for a long time. So there's probably not any really new ideas you can come up with, but there also are a lot of excuses for why people haven't done things that ideas have been around for a while. And so I think innovating is like, in that case, is like pretty hard work because you have to do like, you have to meet with the attorneys and say, well, what if we do this? What if the language says this in the contract? What if we do this legal structure, And so that's kind of what innovation looks like. It's not as fancy as like standing up at a whiteboard necessarily, but like that is the way you kind of further opportunities and pursue opportunities that people haven't been able to capture. Um, the other thing I'd say, two things. One is I think data analysis and payer, like to me, payers and data almost synonymous, particularly at the administrative level. The data is extremely complex. Payers are very are a nexus for data. And it's kind of like Derrick was talking about. I mean, if you're going to work in the payer, get ready to do a lot of data analysis, or at least be exposed to a lot. And that comes back to the critical thinking. You have to be able to ascertain if the data doesn't look right, something doesn't feel right, somebody's misinterpreting, they're drawing a conclusion that's maybe not appropriate, or an off-base hypothesis. And the last thing I'd say is that I was really fortunate to graduate right before the Affordable Care Act was passed. And I was a consultant at the time where all of a sudden, all these hospitals, payers were like, how are we going to deal with Affordable Care Act? So that afforded me the opportunity to get some subject matter expertise. And then for a very long time, I just like coasted on that expertise. I just want to say it was like very precious knowledge, right? And so I think we're going through a similar type of time now, between the Medicaid and what's happening with rural providers. In healthcare, things are a little more bound. So, like, change is opportunity. There's always opportunity to make money for somebody in change, and there's going to be a lot of change. So, what are the opportunities come with that? I don't know, but we're about to have a lot of change over the next couple of years in healthcare, both in the government and on the commercial side. The payer sector is kind of going through some things right now too. So that's a really neat opportunity. That just doesn't happen every couple of years in your career. That's like a every 15 years thing. And to think you guys could be, graduating right at a time when that's happening, that's pretty special.
Great. And a very positive way to look at all of the change. I know a lot of folks do a little bit of griping, but you all have put a really, I think, wonderful spin on, what the students have to look forward to, and how exciting it is sometimes to be in on the great change that, the waves of change that come through. So you talked a bit about the skills. Now, can you tell us a little bit about when you were in school? And that could be undergrad, it could be your graduate program. But were there special skill building opportunities that could be courses, that could be other things, or experiences that you might recommend to start kind of building some of these transferable skill sets?
Oh yeah, I can go first on this one. I would first of all encourage you to take as many finance and accounting classes as your eyeballs can stomach. And these are not the most like scintillating topics, but it will pay dividends to have some expertise in that because most people take the minimum and then they move on. And so if you can differentiate a little bit by having more expertise in those topics, I think it'll pay dividends. And then the other thing is, you have some great opportunities to hone your public speaking and negotiation skills. That is not easy to do once you get out I mean, you're going to crash yourself against the rocks trying to do that in industry. So I would really lean into those things that are maybe a little bit uncomfortable, but like they're skills that will reverberate across your career. And same type of thing. If you're really good at giving a presentation, really good at negotiating, you will stand out. Most people are not.
Yeah.
I think talking to, like, if specifically payers what you're interested in, if we're talking about the big payers, the 6, 7, however many there are, it would be just try to talk to as many people one-on-one or whatever, like things like this, because there's just so many, I can't understate, there's so many different roles at these companies. I know in pharma, a lot of folks just go through the marketing, nothing wrong with that. That's where a lot of the roles for the pharma, when they come to Keenan Flagler, that's what they're looking for. But when you go into Humana's, Cigna's, whatever, there's just not millions, but there's so many roles that, without speaking with people, you won't, find out what they are until you get there, kind of thing. So you might be like ahead of the curve if you go in knowing exactly what you want. And especially it's going to impress somebody in an interview if you say, oh, I really want to be in payment integrity or whatever, it's going to be a light bulb. Oh, wow, this person's done their research. They're really interested.
Yeah. I think that one of the more valuable, like experiential learning things I did was, and this is not like a paid plug, like, but I did do STAR and I didn't want to be a consultant and I still did STAR. And like, I would recommend that and take, like, I took like similar to sort of the finance recommendation, like I took consulting courses and like I think I did like a startup valuation class. Like I did the kind of things where I was like, what is this kind of, not my only opportunity to do, but what is this the chance to be exposed to that is not necessarily going to be a part of the day-to-day that I am going to choose because I already know I'm interested in it. And I really took advantage of those opportunities and I'm glad I did. And then I don't know, I also think just like critical thinking and research, like I don't think you can undervalue how important that is. The number of times that people ask me a question that I find the answer to in like 5 minutes, like it just, I do think it kind of sets you apart. Because you can kind of think about what's going on and ask better questions. I do think like a lot of what is good to train yourself in is asking good questions. Which again, I feel like a lot of that I got from a lot of the consulting like mentors and coursework that I ended up doing because it just puts you in this time box of having to like figure out and address a problem in very short order. And I mean, what is a job if not that again and again and again? You're just not being, contracted and paid in quite the same way or teamed the same way. So I thought those were really valuable for me, even though it wasn't, again, like explicitly I don't even think I ended up with a concentration because I did too many things, which was great.
Yeah. And I think that gives you everything you all said, just kind of rounds out like a student experience in whatever program in which they're seeking. Plus, I think kind of looking outside of your program every once in a while to gain some experiences there can really be helpful. Amelia, I really like that you mentioned, although I didn't want to be a consultant, doing STAR, again, STAR is open to business students or business minors. But there are some other ways if you are not in the business school. So I just kind of popped in the chat. There's a nursing 625, I think 625I, and it's solving complex cases, but it does the same type of thing. It brings you through kind of like that structured thinking and being able to look at complex cases in healthcare and to translate some ideas about that, and then you have to present at the end. And that's open to all students, even though it says nursing. I know people get nervous. They think they're going to be in clinic. This is not clinical, but I just wanted to plug this for all the students out there who might want to really kind of try that kind of consulting within cases here. Plus, I've heard improv. I don't know if any of you all took the improv classes.
I took it. I thought about saying it, but I didn't. But yeah, that's a great experience. If you can do that, is really good. I think.
What is it?
Improv for.
Oh, improv. Yeah. That one fills up quick. Yeah.
Yeah. I think I did it no, it wasn't my final semester because that was COVID and I audited like a million classes because what else was I doing?
Yeah.
But yeah, improv was great. Highly recommend. And obviously like do the class if you can, but like taking improv at all is like that's a decent skill. I mean, it's a Michael Scott quote, but it's like, it's an improvisation, like it's an improv conversation. It's an improvisation. Like every conversation is an improvisation to an extent. And especially like, I think to Luke's point about being good at presenting and negotiating, like being comfortable with that amount of uncertainty and like reacting to what you're being given, but like in a productive way, in a very yes and way, if you will, it is quite a transferable skill set. And I do think, I mean, like a lot of executive presence, a lot of times I do think sometimes if it's not maybe the way you naturally drift, like it is kind of acting. And so it's not, so we don't always necessarily call it that, but it is. And it's okay to just be like, yeah, this is my executive face. I'm in my executive mentality.
And that helps people often who are introverts. When you put your social face on, then it's much easier. Great. And just to add, also case competitions, any types of competitions across the university, no matter what your specialty is.
The interdisciplinary ones are great too. Like, sorry, I didn't mean to interrupt you, but I did one too that was like with the School of Pharmacy. Like it's just like it's such a great opportunity to be at UNC and have so many schools at your disposal. So sorry, Susan, keep going.
Oh, no. I love the contribution. So I think that those are just fantastic opportunities for students, but take advantage now because they're all available to you. So I am going to pause again and ask the audience if there are any questions at this time. We've got a silent group today. All right, Thomas.
Hi, I'm Thomas Foster. I'm doing my executive MBA at UNC Kenan-Flagler, but I have a question about Medicare Advantage and some of the struggles the payers have had with Medicare Advantage. What's kind of your outlook for the Medicare Advantage program going forward?
I would say it's gonna be a rough couple of years, I think, for Medicare Advantage. I mean, it kind of has been in recent past, and kind of like I said, there's a phenomenon. I mean, everything in healthcare is cyclical, but there's a phenomenon in health insurance called the underwriting cycle, and I think it's widely accepted. We're in what's called the hard phase, which is basically where insurance companies are kind of rationalizing their footprint. They're pulling out of counties. They're leaning benefits. They're raising premiums. Competition is sort of resetting, I would think a little bit. So there's that. And that's really a response to the fact that Medicare Advantage grew like gangbusters for years and years, and I think it got a little bit out over its skis. Now also you have the effect of just a lot more government oversight and things like upcoding. And so that's another kind of thing that's rationalizing things a little bit. But I think the next couple of years will be a little bit of a reset, probably, leaning benefits, a little bit less choice. But then the good news is it's a cycle, and it will reset again where it will be in a growth phase where there's a lot more choice and better pricing and things like that. That's, I would guess, maybe a couple of years down the road.
Yeah, I don't have much to add. I think it's interesting though, like the provider payer, it's like a cat and mouse game. And at least in our market, we're getting a lot of pushback from providers. MA has to work for both the providers and the payers. And if it doesn't work for the providers, they just cut bait. And so kind of starting to see more of that. So maybe that goes to Luke's point about a cycle, but I think it is interesting, and I don't know if you guys follow the marketplace, the Ambetter, or well, we call it Ambetter, but those premiums are going up. I think whatever 20% or whatever. A lot of change going on. So yeah, it's interesting.
Yes, I have nothing more to add. But yeah, I got to like watch that happen a little bit. That sort of, we've been in this growth phase, and just like watching it constrict over the early part of my time at Humana. And so it's just, again, like, I think kind of, Luke, back to your point about the opportunities for innovation, like that's in those times, that's also like where they are, is like, how do we do more with less, make more effective, efficient choices. And so, yeah, but yes, the pendulum swing continues.
Derrick also had a good point that's worth mentioning, which is a lot of providers, souring on Medicare Advantage.
Mm-hmm.
Medicare Advantage is typically not like a great reimbursing payer for providers. It's usually around Medicare, a little bit worse. And so it's compared to commercial, it's not ideal, and it doesn't pay as steadily as traditional Medicare does. So so on that, it's a challenging payer for providers. And I think if you just think about what we've all gone through over the past couple of years with inflation, the same thing's definitely true for medical providers. And what hasn't happened is the reimbursement going up 40 and 50% the way some of their costs have. So I think that probably is bound for a reckoning. To Derrick's point, like maybe some of them will term out. They say, I don't know, we're not taking Medicare Advantage anymore. We can't turn a buck on this. But I would say also like there's the system's dynamic. If that starts to happen, the Medicare Advantage insurers will get right and find a way to kind of stop the bleeding from their networks. So it'll be interesting to see like how that plays out. But I think also providers now they're looking at a lot of Medicaid cuts. They probably can't afford
Yeah.
to also cut Medicare Advantage,
Yeah.
Great, insightful answers. And Thomas, thanks for the terrific question. And again, audience, and you can ask any questions about the companies, the folks, their roles.
Yeah.
All right, Arthur.
Everyone, can you hear me okay?
Mm-hmm.
Yep.
Okay. Yeah, I just wanted to go back to something Luke said a little bit ago about primary care gaps in rural areas, and patients are maybe starting to rely more on pharmacists and pharmacies in those areas, but there's also an issue with pharmacies closing because of poor reimbursement models. So how are you seeing this being combated? Are there any solutions in the near horizon, or is this something that, might be a little bit more out of your hands?
Well, you've definitely centered on a point that's like, on all of our minds at Homeward. And we actually do have partnerships with pharmacies because there's only so many like touch points in the market, that a patient interacts with. Rural people don't go to the doctor as much. And they just generally have like kind of a lot of deferred maintenance in their healthcare. And so it's like you got to, if they're in front of somebody, it's like you got to close a gap. You got to do something. And so we use pharmacies for partnerships with that. I would say in general, I feel not good about the rural providers. I think particularly with the Medicaid stuff, and then also just the general market forces. Like the story of my career in healthcare has been consolidation, the payer consolidation, the provider consolidation. And so like in Michigan, if you all are familiar with Michigan, there's an Upper Peninsula. It's basically, most people think it's like Canada or Wisconsin or whatever, but it's part of Michigan, and it's very, very rural. It's basically like Alaska, and a lot of mining and forestry and things like that. And what we see in the Upper Peninsula is that it used to be independent hospitals. Then they kind of got bought by these really large provider systems that are either domiciled in Michigan or Wisconsin. And now what they're doing is they're starting to close those facilities. Because if you're a mega system and you've got all these other hospitals, there's this like one little hospital that's kind of in your hair, kind of you can't make them numbers work, whatever. That's what's going to get caught. Well, that's the rural hospital. That doesn't exist in urban centers. So I think that the dynamics are not good for rural healthcare. And what that probably means is just a lot more virtual care. And unfortunately, a lot more, going back to the deferred maintenance in the healthcare, a lot more people missing care, having to travel further. It's very common in Michigan for people to have to travel 5-6 hours down into Wisconsin or downstate to a place in Michigan to get like cancer care or something like that. So it probably is cancer care now, but it'll be like gastroenterology in 5 years. After that, it'll be like primary care, so that frontier of services is kind of moving out from them.
Yeah, we see that a good bit with like our Medicaid contracts, like the way we're kind of closing those gaps in the places. Like we'll get network adequacy standards from a state, and there literally is not a provider registered in their system to fill that standard in the county or area that we need to. And so like I see a little bit of innovation on the Medicaid side but it is, to your point, Luke, just all very virtual care, which has its limitations. But a lot of that, I mean, I think some of the bright spots in that maybe around like behavioral health, and getting people more access to that. But, like internet coverage isn't even necessarily like a given so it's, I don't want to be too sad about it, but I am. But yeah, it's interesting to see it play out across both of those kind of lines of business, because we definitely see it a lot in Medicaid.
Yeah, and I think the real distinction in rural is like, I mean, actually anything in healthcare to me is about the demography. So when I lived in Texas in Austin, you could be in any sector of healthcare. It was great because the population was growing 5 to 8% a year. In Michigan, we have parts that are growing, most of it's declining. And once the demography starts to decline, whether that's aging population, average age, or declining actual like nominal population, that's kind of the beginning of the end for healthcare services. It's very difficult to arrest.
Derrick, do you have anything to contribute here?
No, I think it was a great question though. I think pharmacists could be an answer. It's worth looking into for sure.
Thanks, Arthur. And Claire.
I'm full of questions. Hopefully this one kind of makes sense. I heard someone recently mention how health insurance is very different than typical insurance. With like car insurance, you wouldn't use that insurance to go get an oil change for your regular maintenance, but with healthcare, you go do your primary care with that health insurance. So I'm curious, from your guys' perspective, what really is the distinction between health insurance plans versus how people generally think about insurance?
Yeah, I mean that whoever said that was correct. Yeah, it's interesting. Um, I think there's different types of ideas that are trying to get more skin in the game for the patients. If you ask Derrick Brusseau what he thinks, I think that's good because at the end of the day, you have a provider who's not paying for it and a patient who's not paying for it. And I'm not saying there's nefarious things going on, but they don't always equal, cost savings. And so you end up with 5-8% annual inflation in healthcare. I don't know how much you guys work with ICHRA plans. It would be worth something for students to research. I don't know a whole lot about it, so I can't speak to it, but at least at Centene, we're kind of bullish on it, and it's a different type of health plan where, from my understanding, you're given money, you go find a health plan on the insurance marketplaces, and I guess rather than coming out of pocket for it, you're kind of more responsible. I think it's a step in the right direction. But yeah, I mean, if you ask me, I think patients need to get a little more skin in the game. I know research kind of shows that is iffy on whether that, decrease if people still end up receiving care and that they need. But from an economic standpoint, I think it makes sense. I don't know if maybe I offended some people by saying that. But.
No, I think there's a lot of literature that says, when people pay for something, they value it more. And it's true about healthcare too, at least compared to free services. But then that does leave some portion of the population that can't afford it. It's kind of, there's a give and take
Yeah.
there. Amelia, what do you think? You want to take the next one?
I don't have anything particularly insightful to add. And it is a little different. I mean, I don't know. I will say, because like working in Medicaid, it's a lot more like B2B, because like we're working with the states and they're dictating our contract. And so like we need to meet the needs of their population the way they've defined it. And it is quite interesting from like the value-based perspective. I was just working on a project in South Carolina, and like we needed to talk about sort of some potentially complementary like value-based programs, but we needed to evaluate the state's program against our program to make sure that we weren't somehow like incentivizing providers in different directions. And I think that's something that probably warrants like a lot more attention as we move more into like value-based continuum type efforts, because it's just really easy to put for well-meaning actors to put in place competing incentives that don't do anyone any good, the provider nor the patient. And I'm kind of like going on a bit of a tangent here, but that's just what occurs to me about the incentive structure. And I guess the difference between the oil change example is like, you know, how much an oil change costs. Like you can compare prices that are available like from the different shops. And that's obviously a challenge. And I don't even think that putting in place transparency legislation like necessarily helps all that much, because the way the rates are negotiated are so complex. And so I do think that might be the complex piece of it, is like understanding what the cost of things are, and getting that into terms where folks can evaluate it for like what it means to them and why that investment is worth it, like from a patient perspective. So that's my nonsensical tangent answer, but the incentive piece I think is like a lot of it, and just bears consideration and reflection just to make sure, because a lot of times it is just, it's very minimal, but it is just like, well, we've asked the provider to report this, and this other group has asked them to report this, and like they're focusing on reporting these things to us, but is it actually getting something for the patient?
I would say that like there are instances where there are health insurance products. I mean, the same way that these companies diversified, there's a million different types of insurance products now, from like critical illness to like Christian cost sharing ministries and things like that. The ICHRA plans, you know, that Derrick mentioned as well. And so you could probably find a product that like actually pretty closely resembles auto insurance. But I think the main difference is that auto insurance, like when you buy health insurance the way we think of health insurance, you know, the kind of ID cards we all have, it's kind of like being part of Costco or being part of like it's like a group purchasing, you know, collaborative. And so what that insurance company has done is they've gone out and they've procured contracts for care that is available in the market. And then also they procured, you know, contracts with your employer or whatever to provide that care. And like compared to car insurance, where it's like, well, you might wreck once every 10 years and maybe it's fender bender, maybe it's a big one. You know, health insurance is like everybody needs healthcare every day type of thing. And some of it is really ticky tack stuff that's basically free, like vaccines. And some of it is like, you know, a NICU baby that's like many millions of dollars or something. And so I think the difference is that like that exercise like much more actuarially complex in health insurance, and you have to figure like how long people are going to live. If we make this service available, will they live longer? Will they use less of this other service? It's like a lot more trade-offs, I think, than you would find, you know, with health insurance or auto insurance.
Talk about GLPs and if they're going to save. Are they going to save money or not? You know, we
Oh, I
recruit.
thought you were going to say like save humanity or something, and I was
No,
like, oh, I
well,
don't know.
I think it's, you
money.
know, insurers will be for it if it reduced enough healthcare costs, you know.
Yeah.
Yeah. And I think that bar is pretty high for insurers to say something's worth it. You know, that's why you see a lot of like prior auth and step therapy and stuff like that. Because, you know, a lot of times we're just not 100% sure that something's really going to be effective in healthcare. Or, you know, truly, what is the value of healthcare? What is something worth? You pay $1,000 for a surgery. Maybe you get out of it and you're like, I should only paid $800 for that. Maybe you're like, I'm the richest man in the world now. You know, that was worth $1 million to me. So, yeah, I think it's difficult to discern that value of the services, you know?
Yeah.
Again, great answers, but yet levels of complication in healthcare as always. But that gives hopefully our audience something to think about. But I hope what they took away from this was do your research, go out there, just kind of dig around what's going on. You know, what is the policy? What are the policy changes right now? What are different companies doing? I just put an example of the ICHRA in there. Just kind of just look around to get to know what is kind of coming on board. And that's what I want to do in our last minute for like, let's give 15 seconds each person. Just what trend do you see is going to be big in the next 10 years for your industry and or your role or company?
I'll jump in. So I think, I mean, well, I'll answer it in a different way. I think for your careers, there's the giant healthcare organizations, and then there's so many because there's so much opportunity to change in healthcare. I don't think you're going to change, the large, trajectory of where healthcare is going, but there's so many companies like Luke's that, and even Strive Health where I used to work, that I think are doing a lot of great things too. So you kind of have your pick of like, do you want to go with the large ones or the smaller ones? I think those startups, there's so much money going into these startups. They're doing a lot of great things. So I think it's great to start at a big company and kind of keep a pulse on what these more startup-y companies are doing, where they're focused, where they see opportunity. I think that'll be a good thing for the next 10 years.
Yeah, I feel like I should let Luke close out because I think he's going to have the most insightful thing to say.
I don't know about that.
I don't know.
Good.
I feel like this is, I don't want to be the person to say AI. I don't want to, but I don't think that's an answer, but I do just think it's interesting to see like how we're incorporating it, and what the opportunities for like more proprietary applications are of like to Luke's point earlier, there's just these massive amounts of data, and like if you can use them in the right way. I mean, I think that's just always been the question, is like if you can use this in the right way, like you've got something great on your hands. And everybody thinks that the next advancement is going to be the answer, but I think that it is interesting to see like the distinct use cases that are being applied, because I don't think that it is like holistically just a salvation in and of itself, but looking at some more tailored applications is kind of exciting to think about what it could free up some of our capacity that is like spent on ticky-tacky things that we don't need to be doing, if we can automate them. And I also think sometimes AI is confused for automation, because that's a big thing too. So yeah, I do think those are exciting. It seems like we're getting to a point where people are able to kind of develop those a bit internally and apply them. So it'll be interesting to see. I don't think it's going to change anything overnight, but it does seem to have some promise.
Yeah, I think I mean, I joke sometimes that like if you think AI is gonna fix all the problems in healthcare, then you don't understand AI and you probably don't understand healthcare either. But I do think AI is gonna be like transformational in terms of like there's still a lot of manual stuff. Like, do you know like faxing stuff is like one of the most HIPAA secure ways to transmit information? It's like, come on, 2025, really? So I do think it will drive a lot of like efficiency, but it was all stuff that we shouldn't be dealing with in the first place. So I actually think what is probably going to be really transformational the next couple of years is that besides the Affordable Care Act, we haven't had really massive like regulatory change, and I have a gut feeling that that this administration would like to do that if they could, and those effects tend to reverberate over like a decade or more. So like when I was a kid, we didn't have EMTALA, we didn't have HIPAA or anything. And these are like this is like the superstructure of all healthcare delivery and services at this point is HIPAA and EMTALA. You know, Medicare Part D didn't exist barely 20 years ago. So I think that there probably will be some of those that probably won't be immediately evident in terms of change, but it will, again, will have this like almost like epic long-term change. And I don't know what that would look like. It could be reform of Medicare Advantage or some of these other regulations that just providers have been complaining about for years.
Well, terrific. Thank you for those final insights. And I do know we're a few minutes over, but I cannot thank our audience members enough. And I cannot thank our great panelists enough. You all were so insightful tonight, and I hope the audience got a lot out of this. But again, thank you so much. And we hope that everybody can join us for the next panel. I'm popping that in there. It's October 21st. But again, your time is valuable to us. Thanks for going ahead and investing in UNC and the Center for the Business of Health. I hope everybody has a great night.
Bye, y'all.
Thank
Thank you all.
Have a good one.
Thanks, everyone.
Thank you.